Today we're going to be talking about discharge summaries, and I know this is not the most exciting topic in the whole world. It's probably one of my drier talks, and I apologize for that. But my goal here is really to try to make your lives easier. I'm going to try to show you some tips and tricks and shortcuts and guidelines on how to get the discharge summary done, and hopefully make it something that's not quite as complicated for you. Please feel free to stop me, ask questions, how did you do that again, show me. It's really boring if I just talk at you guys for an hour or whatever, so stop me anytime. I'm just so happy again to be in person. I did this on Zoom last year, and you can imagine how dry it would have been on Zoom, so consider yourself lucky. Okay, so we'll start off with, all talks start with disclosures. I have none, except to say there really isn't one right way to do a discharge summary, so I'm going to tell you a lot about the things that I do to make my life easier, and a lot of things that, what primary care doctors are looking for and things like that, but each situation is unique. Everyone's a little bit different, and so you don't have to do it exactly this way. There are a lot of less than optimal ways, though, so we'll try to avoid those less than optimal ways. So, first I want to start, because you guys are mostly new to MedConnect. I know it's not the most intuitive system in the world. A lot of this is going to be like workarounds. How do I deal with MedConnect and its intricacies? So some things we're going to be talking about are the discharge summary itself, which is a document. The document ends up looking like this. I'm sure you've all seen it by now. And the way that you find that is in, let me just pronounce here, in the provider view, in the discharge workflow. When you scroll all the way down to the bottom of this menu, you can create the note discharge summary. I'm hoping you've all done that by now. Another thing we'll talk about is called the discharge workflow, and that is a section of MedConnect. It's an area that we're going to be looking for, and this is really the first place to go to start and complete the majority of the discharge process. And so what this looks like is, again, in the provider view, and then go to the discharge workflow tab. Most of you will be in, I'm hospitalist, so I think you're internal medicine tab or something like that. And then lastly, there is a discharge order set. So yes, you can place a single discharge order for just discharge the patient, but there is an order set when you search for it. If you look for this little, geometric shape icon, it stands for order set. And when you do that, you get a collection of orders. What am I doing? Oh, okay. Now they can see. Okay, that's even better. Perfect. Then you get a collection of orders grouped together so that you don't forget some of the components of an ideal discharge. Yes, you can just put the order in, but I'll try to convince you why there's a better way to do that. And now there we go. Okay, so in order to discharge somebody, hopefully a lot of you have been through this already, but you need 5 things specifically. The computer will not let you discharge them without these 5 things. So you need the problem list, the follow-up, the patient education, the medication reconciliation. You find all this in the discharge workflow section, and then you actually need the order. And again, order set, I think, is better. I'm going to recommend to you that you do all these things before you even create the discharge summary document, and then it makes the document a little bit easier to update and deal with, and I'll show you all that. If not, you'll just need to refresh the document whenever you update these things, and I'll show you that too. Okay, so again, I'm showing you the provider view, the discharge workflow. You can rearrange the order of all the components in any of these views. And as you notice, there are 4 things with a red asterisk by it, and these are the 4 things that are required. The computer won't let you discharge without it. So what I have done for myself is I brought them all to the top so that they're immediately available right there in the order that I want to do them. You may certainly rearrange them at your will, and then it just makes my life a little bit easier when I do that. So I'm going to start with just some general tips. And my big message to you guys is less is more. Be concise. So I know a lot of you are just coming from medical school when we're very excited about, being on top of every detail and telling every little bit of the story. But think about who's actually your audience reading this discharge summary document. It's going to be a busy primary care doctor. It's going to be you when you're admitting in the ER next time the patient comes in. It's going to be specialists who need to scan quickly and figure out what they need to know. So, a lot of these people don't have time to get down in the weeds and don't really want to get down in the weeds. So really think about what is the information that I actually need to convey, and leave out the extraneous details. And we'll talk about what are some details. MedConnect's not the greatest for making a document super easy to read, so try to do what you can to bold, highlight, whatever, to try to bring out what really is important in the document. And then hopefully you've been exposed a little bit before now, but I'll go through it. There's a hospital course section of the workflow area where we keep track of a lot of these things, and it really, truly does make your life easier if you're updating this hospital course on a regular basis, daily, every other day, so that when it comes time for the discharge summary, you're not scrambling to get 2 weeks of a hospitalization together. It's all kind of right there for you already. And then I'm just going to put my bias up front. I hate clutter. You can ask my husband about that. I will drive him crazy about clutter. And so I'm going to encourage you to keep clutter out of your discharge summary as well. Make it easy for the next person to read and make it a little bit simpler for you to create as well. So making your life easier, as I said, keep track of everything in the hospital course section. You can create a smart text for yourself. So in any of these white boxes that you find in MedConnect, you will see this little icon right here. And if you click on that, what you'll find is this menu. These are auto texts that I have already created for myself. If I wanted to create a new one, I would press this little plus sign button to create my new auto text. And then what I do is I create any name. I think I've made it like hospital course or something like that. And I have this little trigger for my memory of what needs to be in the discharge summary. So I have a summary, hospital course by problem, procedures, consults, diagnostics, discharge plan, all the stuff that we need to keep track of on a regular basis. I'm hoping a lot of you have seen that already because I know a lot of the senior residents have been doing that and showing you that. Okay, so like I said, this is the discharge summary document. What I'm going to do right now is actually just go through section by section and talk about what should be in there, what's the easiest way to actually accomplish getting it in there to make your time a little more efficient. And again, stop me anytime, please. Okay, so I'm going to go through section by section, but just if you step back and look at the big picture, the document actually does make sense. When you think about why was this patient in the hospital, what do I need to know? Well, we're starting with just the logistics. What's the date? Who was the doctor? What were the diagnoses? What happened? The hospitalization summary and its components. What are their discharge medications? What are some of the key results that I need to know about? And then what is actually happening on discharge? How is the patient? Where is the patient going? What are their instructions? And so if you step back and think about the big picture and how this all fits into the summary, it'll kind of help guide you through what to include and what needs to be there. So we'll start with general discharge information. As you've probably seen, a lot of things are automatically populated. The discharge date, admission date, attending. Really, really important to make sure that the PCP is actually accurate. So when you see on the blue banner, a lot of patients will have a PCP already listed. Remember that these are done by the intake team. These are non-clinical people. They're just asking, or sometimes they're not asking, they're accepting what was in there before. And so they're not always the most up-to-date and accurate. So it's really important, hopefully the admission team, or if you get them the next day, checking to make sure their PCP is accurate. If not, you can actually place an order to change the PCP, and that's how you would update that. Don't forget to add the discharge date. So why am I so concerned about the PCP? Well, obviously many reasons are very important, but one of the main ones is that I have an admin team, my hospital group has an admin team, that takes every discharge summary and sends the information to every specialist and PCP listed on it. And so at the time of discharge, usually it's a couple days later, just logistically, they'll see this is the PCP, send it to them either through the computer or through the fax. And that's our main way of getting this follow-up information to the patient's outpatient doctors. And so as long as everything that you list on the summary is accurate, we can ensure that the documents get there to where they need to go. Now, that being said, as I said, it takes a couple days just because of the logistics of everything. So if there's something that this PCP needs to know like tomorrow, then that's when you want to pick up the phone, give them a call, or fax the document over. But for the most part, the documents will go to anybody who's listed on them. And if for whatever reason it's not accurate and you haven't you haven't updated the order, just list the name and phone number, and my office will be able to figure out how to get it there. Okay. Yes, please.
It doesn't matter where in the document we put the name and phone number?
It doesn't matter where. Up top is where the PCP is generally listed, but if it's at the bottom in like instructions, that's fine too.
I have a question. The other day I tried doing an order to change the PCP, and I couldn't actually find it. I tried to PCP.
Type in primary.
Oh.
I just did it like 20 minutes ago.
Okay.
Type in primary, yeah.
Okay.
Okay, so as you know, we list the discharge diagnoses. And it's really important to include a list of all diagnoses that the patient had or we thought about during the hospitalization. Now, why is it? this is Georgetown Hospital. We have sick patients, it's a tertiary care center, they're very complicated. If we didn't reflect that in our actual like coding and documentation, it would look really terrible for us, right? Because we would have poorer outcomes than what would be expected for the level of sickness for our patients. And so one of the reasons we'll do this, and I'll admit it's like not for educational reasons, although I think there are some that I could talk about, is really to reflect that we have sick patients and we want to make sure that we get quote unquote credit for that when we're thinking about just general outcomes. So what does that mean, all diagnoses? Well, if you thought about it during the hospitalization, and even if thinking about it just means like continue their home blood pressure medication, well, you had to weigh that into consideration, right? Was their home medication lisinopril? Do I need to hold that? Does it interact with other medications? So all of this like thought work that we do, we should get credit for counting all that thought work that we do. And then it's also helpful, you know, when you glance at the discharge document, having that list of diagnoses up top is a quick overview for the next person taking over the document. So how do you get these up to date and accurate? Again, this is where we're back to our discharge workflow here. And I have my problem list right at the top. You can move it around to wherever you want it. Again, you can rearrange. So one common thing that you'll run into is sometimes the emergency department will put in some diagnoses, and if you like them and you want to keep them, what you have to do is actually put this little drop-down arrow there and put a number by it. For whatever reason, it won't count it unless there's a number by it. And so I've definitely had people run into the problem where they're trying to discharge somebody and the computer won't let them because it says problem list not complete, and that's usually why. Just make sure you have a number right here. If there's not something that's already on their list, you can search for any diagnosis right here. Good news is this is a much easier search than the orders in MediConnect. It doesn't have to be exact. It doesn't have to be like, you know, the correct phrasing or whatever. It's a pretty broad search overall. And so just type in whatever diagnosis you're looking for, and it's pretty easy for them to come up on the list. If they're already on the list, let's say this patient was here for, gosh, I can't even see this. Brain tumor, and that was part of the reason or part of the things I thought about during their admission, I would just click this visit button and it would pop up top with a number by it, so I would immediately get credit for that diagnosis. And so anything that the patient already has on their list, you don't have to type it in, you just click, 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 anything that was relevant to that hospitalization. If you add a new diagnosis, consider for your next colleague who's on later, clicking the chronic button so that later on it also appears here in this list, and then you make someone's life easier later on when all they have to do is click a button instead of searching for a diagnosis. One common thing is that, you know, we have our notes with like a long list of diagnoses in them, and a lot of them we're not keeping track of day by day. They might not be forefront in our head, and it's a pain to like click back and forth between screens. So one way that I get around that is if you hover over, or if you go to the hospital course section, oh, you guys can't see it. Oh, there it is. Can you see that little red circle right there? There is something covered up there by the screen over here. I'm sorry about that, but there's a little icon that looks like an arrow pointing to the right. And what that will do is pop out the hospital course section to the right of everything else so that you can have it here, look at all your diagnoses at the same time that you're populating the problem list. So this helps me out for a lot of it, the follow-up that, you know, we'll get to all that. If you, I know you can't see it, I'm sorry, the screen cuts it off, but there's just a little arrow right here that pops it out to the side. So it will always be there on the side as you scroll up and down. So that's how I do my problem list. And then if you want to pop it back in, again, same button right there.
I think you can move the...
Can I move this?
Yeah.
Thank you. I swear I'm not that old, but I guess I am now technologically challenged. Okay, so that's what your little button looks like. So in the end, when I'm actually ready to discharge a patient, this is what my problem list is looking like now. I have all these diagnoses that I addressed during this visit. Some of these are chronic, so I'm going to check it so that they pop back later and they're already on the past medical history. And when I create my discharge summary, boom, now I have my list of diagnoses. So that's where that comes from. Okay, there's a section under that called Diagnoses Resolve This Visit. Just know that this was requested by other hospitals. You don't have to fill this out if you don't want to. It's free text. If you ignore it, anything in the document that you just don't put anything under, it just disappears in the final document. You feel free to ignore it if you want to. Okay, So now we're getting down to the hospitalization summary, which I feel like is sort of the meat of the discharge summary, the hardest part for us to keep track of on a day-to-day basis, and kind of the hardest part to summarize too, right? What to include, what to leave out, what does concise mean. So I kind of explained it as like, tell the story, let everybody know what they need to know, but don't waste anyone's time. And so think about that being your guiding principle. A long time ago, probably 3 years ago now, the HPI used to be its own section of the discharge summary. And so you will frequently see senior residents copying forward the HPI into the discharge document. That's fine. It's not hurting anybody, but it's actually not necessary. You don't need to have that as part of the document. And so to me, it adds unnecessary clutter. I don't want to skim through that to figure out what's relevant and what's not. And so what I do instead is just do the 1 to 2 line patient summary, the one you give on rounds, the one that's at the top of your assessment and plan. That really should summarize the presentation overall pretty concisely. If they really want to know the HPI, well, they can go look at the HPI. So then in general, we do the hospital course by problem. I know you guys have all seen that many times already, except sometimes there'll be a short or simple hospital course that maybe I can summarize in a couple lines or a paragraph, and it's perfectly fine to do it that way too. So whatever is best for your particular patient and your situation. Our patients are so complicated that usually it's by problem, but it doesn't have to be. It's really important to think about the specificity of your problems, right? So is the patient diagnosed with dyspnea, or are they diagnosed with acute systolic congestive heart failure exacerbation, right? The specificity is really important, not only in reflecting the sickness of the patient, but if you're the next person taking care of that patient, it really gives you a crisp, quick idea of what exactly was going on with that patient. So when you're entering them in the problem list, when you're updating your hospital course, as the problems change, you might find out more and more information. Update the names of those problems to be as specific as you can. It's also a great exercise I tell to the medical students to try to really think about how specific can I name this problem, and they really understand what's going on with the patient. And I know early in your career it can be kind of overwhelming to get the big picture of what's going on with the patient, so it can help in that way too. Generally in order of importance, don't leave the most important problem at the bottom, put it up there where everybody can see it. And then think about the details that the next physician will need, and I'll get to that in just a second. Think about the follow-up plan. You know, this is what we did in the hospital, this is the next step. And don't include those extraneous details, be concise. So here's an example. I am not going to read through this. I will send you these slides. You're welcome to read through this. These are just examples of, I think this patient was a new PE in the setting of thrombocytopenia, and how I decided to summarize that problem, giving what needs to be done, the follow-up plan, but not giving all the extraneous details. Here's another example. This one's a little bit different because the diagnosis wasn't known at the time of discharge. And so in this one, I kind of list the collection of problems the patient had. I didn't know why they had those problems. And then talked about, well, this is the workup we've done so far. This is what's still outstanding. This is my plan for discharge and follow-up. So that's another way to do it. And then finally, this is that sort of like paragraph format where this was a pretty straightforward hospital course. So I typed it out into a paragraph. And then to make things even easier, I tried to bold certain parts of it that really brought out the highlights of it. Again, I'm not going to read through this. I'm happy to send you my slides. And working with your senior residents on how to sort of pare down and what to include, not to include, is always a great learning opportunity. And as you learn that, teach your students as well, because I know a lot of the students are helpful by updating the hospital course on a day-to-day basis, and they try to do the best they can. They want to include everything. You know, we increased the Lasix, and then they peed too much, and then we decreased the Lasix, and then we added metolazone, and then their potassium went down. And you don't need all those details, right? Just, we diuresed them to euvolemia. That's all you need to say, right? Okay, so I'm going to pause there for a second, because I know that's where a lot of questions come up about what to include, what not to include, how concise to be, anything you want to bring up. Yeah. Okay, all right. Again, feel free to ask. Yes, please.
So if you have like one main thing that you're working on, but there's like other problems associated with that as a result of that, can you just all put it into one section?
Yeah.
Okay.
Whatever makes the most sense for your patient.
Okay.
Right? So if their main problem was heart failure and then they got like hypokalemia and volume overload pulmonary edema, I might group them all into one problem and just describe briefly how I took care of that.
Gotcha.
And then maybe list like their COPD was stable on home meds, their whatever was stable, blah, 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 just bare minimum.
Thank you.
Yep. Okay, so luckily, that's kind of like the part that I feel like takes the most time and effort, And that's why I really encourage you guys and your students to keep it up to date as much as possible as you go along. Obviously, you have busy days when you can't do that, and that's fine, but, you know, make your lives easier when you can. The rest of this, a lot of it is just knowing where to copy and paste, and that's kind of where I'm going to try to attempt to show you that. So the next section of the discharge summary is procedures. When you're looking at the notes for the patient, so this is where we find our documents, you can click on this drop-down menu here, and there's lots and lots of different choices, including at the very bottom, they're in alphabetical order, surgical and procedures. And so when I click on that, I guess you can't really see it behind there, but what I get is a list of all the procedures. Like, oh, I forgot they had a colonoscopy 2 weeks ago, or the biopsy that they had, or, you know, whatever they had. They're all listed in one section, so I don't have to go through all different parts of the chart trying to find all the different procedures that they had. It's really important not to only include the name and the date of the procedure, but what was the outcome? Was it a colonoscopy? What did they find on that colonoscopy? What are the follow-up recommendations? Was it a biopsy? Do we have the pathology, or are we waiting on the pathology? So anything relevant that the follow-up team would need to know. So talk about that. This is something that you can keep track of in real time in the hospital course section, so that in the end you're not actually clicking on every single one of these. Although, to be perfectly honest, I find it almost faster to do it this way, so whatever works for you. And then I just told you that. Okay. So here's an example. So here's a colonoscopy report. I highlight my impression and follow-up recommendations. I tag them right here, or I can just copy them, either way. And then what will happen, I'll show you this a little bit later. If you tag it, it'll sort of like pop out to the side, your document's here, the little tag's up here, and you just drag it down where you want it to go. Okay, similar idea with consults. You've probably noticed things like case management, pastoral care, all that like populates, and you're like, well, that's not really what I care the most about. Those pop in because you have to put orders in for that, and so that's how they get there. So IR, we also have to put orders in for, and that's how they get there. You are very welcome to put orders for any and every consult you place. Our culture here is that we just don't do that, which is fine. So just don't forget to list all the different subspecialty consults. Were they seen by critical care? Were they seen by cardiology? You know, whatever. And then if you've forgotten, if it's been a long hospital course and you can't remember all the different consults that saw them, same idea. Go to your little drop-down menu, click on consult notes, and you'll see all the different specialties that listed an initial consult note. And then all you have to do is just type out the name, endocrine, GI, whatever. Quick way to do that. Also helpful to keep track in real time. Okay, medications. This is a big one. Obviously, discharge medications is a big deal. This is where a lot of mistakes and misunderstandings and miscommunication can happen, so we really need to be very cautious about the discharge med rec. As you know, the medication list in the discharge summary comes from the med rec. If you need to change anything, if something changes after you've made the document, you have to go back to the med rec, redo it, and then refresh the document. You cannot add anything into the medication section, and that's on purpose. Always be sure to refresh it, make sure it's up to date, be extra cautious. Yes, please.
So if you refresh at the top right, so is that good, or do you have to go to the section and refresh that?
Oh, you're talking about the document versus the section?
Yeah.
The section.
Okay.
Yeah, the section. Yeah, I already sort of went over that. Double and triple check. And actually, there is a push to every single time go over the med rec with your attending. Abra can tell you I've been lazy and haven't been doing that. I'm sorry. But please, like, we all expect to like really go into detail over the med rec. We're happy to go over it during rounds or call later on. You know, please don't leave any questions unanswered about the med rec. Okay, we talked about that. Discontinued medications. MedConnect does not have the capability. Does not have the capability to automatically populate this. But that's what it is. So it's really helpful to keep track of as you go along, and it's also really helpful to include why. So I discontinued lisinopril for hyperkalemia. I discontinued this because their blood pressure was low, whatever. Again, helpful for the next person. Remember that if you free type something into the discharge summary document, the patient doesn't see it. Now, I'll caveat that with, yes, they have the power now to go into the portal and see their discharge summary. Not everybody does that. So if you really want the patient to see what you're writing here, you need to copy and paste it somewhere else, and I'll show you where the best place to put that is. Okay, but before we get there, we're on to the key results section. This one's pretty straightforward. Obviously, you're adding in the lab results. You've all probably found .lab core bundle by now, which is kind of a helpful summary of the ones that print out on cores. But don't just stop there, right? Because if you did a workup for some autoimmune disease, don't leave a question about what was done and what wasn't done, so somebody has to do the workup later. Include all the labs so everybody knows, okay, all these labs are actually done, this is the result, I don't have to repeat it. There is a dot phrase, .labs last 7 days, 14 days, etc. If you've seen it, you know it's really cluttered, it's really difficult to read, so I will try to convince you there's a better way, although again, it's not wrong, it's just probably not ideal. So here are some helpful smart facts for you. Body fluids, so if you did paracentesis, thoracentesis, that'll pull all that in. Note that it only lasts 14 days, I'll tell you a workaround for that in a minute. This is less and less relevant now, which I love, but there's a COVID lab dot phrase. So when we used to track like the LDH and the troponin and the CRP and all that, we have a dot phrase for that. CRP, so I follow a lot of like limb consultations. I put my last 3 CRP results in there. CSF, for whatever reason, it's separate from the body fluid. Glucose last 48 hours is one of my new favorites. That's a pretty new phrase because it lists the date and time of each blood glucose measurement, and so if you're titrating insulin, it makes it easier to, see clearly when the sugars are high and low. Infectious disease and micro since admit, so that's all the serologies, the HIV, the hepatitis, the respiratory viral panel, the T-spot, all those things are pulled in with these phrases, including the cultures. Therapeutic drug levels include vancomycin, tacro, any of those things that we're following. Troponin, last 3 since admission, and tox screen. These are the ones that I found the most helpful. The way that I found this is that one day I had a lot of time, and I typed in .lab, and I looked at all the different choices on there. So if you really feel like going deep, you can certainly do that, but hopefully this will save you a little time. I will say, if you haven't figured it out already, capitals matter, because MedConnect, I'm sorry. So note whether this is a capital letter or a lowercase letter, and that will be a source of your frustration. If you can't find it, try the other one. I'm sorry. Here's another way to find labs. So let's say there are some labs that just don't have a dot phrase, and so you're going to have to find them to bring them into the summary another way. So again, we're going to the discharge workflow. If I'm scrolling down the side now, there's a labs area. And I can change this up here to 48 hours, 24 hours, 7 days, 2 weeks. And what I can do is hold down the control button, click on any number that I want to put in there, and then click this little tag button up here. What that does is it brings it into the discharge summary looking like this. So that's really useful as long as things are pretty recent overall. What happens when you get down to like last month, last 3 months, the computer will take like 9.5 years to load and you'll get really frustrated. So I don't recommend that method. Let me show you a different one. Another way to do this is in the results review here. So you've probably seen this before. Go to the extended labs. This is for somebody who's been here a while. You want to pull in everything. Very helpful hint. Click on this group button right here. And what that does for you is it makes it so you only have to scroll up and down. You don't have to scroll side to side. So it makes the screen a little bit easier to navigate, and it groups things together. So all the creatinines are together, all the hemoglobins are together, instead of going all the way across, which I find pretty difficult. And then what that will also do, if something's been a long time ago, and you don't scroll all the way to the right, you might not even notice that it came back. Whereas if you do it in this view, everything's on the screen. You don't have to worry about scrolling. So then next, click on any lab that you want. Hold down Control to do more than one. Control-C doesn't work, because MedConnect. And then up here, go to Edit, Copy. So for whatever reason, no Control-C, yes, Edit, Copy. Then what you do is go over to your discharge summary and do either the edit paste or surprise Control-V works. I can't explain. And it pops up in this table format like this. And so if I have somebody with a really long hospitalization, what I'll just do is just go to that extended results, click, 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 however many labs I want, copy, paste into the discharge summary. It takes a really short amount of time, and I think is much easier than the tagging version. But there's, again, many, many ways to do the same thing. So this I find extremely important. Does anybody want me to go over that again? Okay, feel free to ask. Okay, we're getting there, guys. Like I said, I know it's dry, I'm sorry. Imaging and diagnostic results. So include anything relevant with the name and the date. Remember that not every chest X-ray is relevant for somebody who's been in the ICU, so use your judgment. Don't include extraneous details and clutter. In general, try to only do the impression or the final read, unless the details are actually important. Sometimes they are, and you use your judgment on that as well. So a couple different easy copy-paste ways to do this. Number one, again, we're back in the results review here. I'm in the diagnostic section, and I double-click on one of these to open them up, and here I have my MRI results. I highlight what I want to include, so for this one I only include the impression, and this little tag button pops up, and so I click tag. And then I do that for as many studies as I want. And then, when I have my, this is my discharge summary document right here, pops over to the side, and if I take that and drag it over into here, it ends up looking like this. So it automatically includes the date, the name of the study, and then whatever I included. So it makes it pretty quick and easy overall. And you can do like a bunch of these in a row. They can all be lined up on the side. You can just drag, 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 drag. Another way to do it, if you sort by diagnostics in this document viewer, just like we did before, a really easy way to see them all in a straight list instead of scrolling from side to side. You can do the exact same thing. Highlight, tag, as many times as you need to. And one final way to do it, again, pop out your hospital course right here. So now it's on the side. And if I scroll down in my discharge view or in my daily view, either way, I now have diagnostics here. I can double click and open them and copy and paste it into the hospital course so that later on when somebody's doing the hospital course at the end, it's already there. So 3 different ways to do it. Pick your favorite. Okay, discharge condition is basically what it sounds like. Really, really important is the physical exam at the time of discharge. Give me 1 second. So it must be on the actual date of discharge. And so if you start the document earlier, that's fine. Just refresh it so the most recent vitals are up to date because they stamp the date and time in the vitals. Or refresh if needed. Think about what the next physician would want to know. So are you discharging a CHF patient? What's their JVP? What's their weight? What does their lungs sound like? How much swelling is in their legs? Or do they have a rash or a wound? What does it look like now? What should the next person be looking for to compare it to? When somebody's going to a facility, we have a separate section for instructions for the facility. So it's things like PCOT, eval and treat, that's the obvious one. Do they have a special texture diet? Do they need puree? Do they need low sodium, low potassium? Do they need supplements? Do they need Ensures? Do they have Lyme? Do they need to flush their drain twice a day? Do they need regular Foley care? Do they need their Foley removed in a week? You know, think about all these different things that we want to try to not let those balls drop because otherwise the facility is sort of like using their best guess, and we would rather tell them what we want them to do. Wound care would go here as well. So I already did that. Anything that we did to them, any lines, tubes, drains, put in the date of placement, and then the care instructions that we talked about, and then any follow-up instructions. So does the PIC need to be pulled at the end of the antibiotics? Should there be a void trial in a week or whatever? That. Discharge condition and location. If you sign, yes, please.
So for that, like that
Yeah.
care section, that's only if they're gonna go to a facility.
Yes, so that's where it's needed. You can populate it in other cases too.
Okay.
So if it makes sense to put it there, by all means, put it there.
What
Yeah.
about like home TPN? Like, would that have
You could certainly put that there. So I could put in, set up with home TPN, needs home health for delivery and flushing the line. Yeah, that kind of stuff. Yeah. If you sign the discharge order before you do the summary, like I mentioned before, this will automatically populate because you put in discharge patient to home or hospice or wherever they're going, and you always have to click that like improve stable button. If not, you can just note it, and all you really have to say is patient is improved, stable, discharged to home, discharged to STAR, whatever it is. That's just like a CMS, like Medicaid requirement for discharge summaries. Okay, instructions. I think this is really the important part, and unfortunate that what we free type here, remember the patient doesn't see. So anything you type into the document, they're not going to see. So let's type something in one place and get it both to the patient's eyes and to the document at the same time. How can we do that? So number 1 is the discharge order set. Anything you put in there, diet, activity, instructions, follow-up, wound care, patient sees all of that. And so I'll show you how to populate that. Another section is the follow-up section of the discharge workflow. So you guys have all seen where you put in like the next provider or follow up with your PCP, anything you put there they see. And then the last section, I don't even think I included it in here, but is the patient education section. So when you free type, like this was your hospital course, anything you put there, the patient. So those are the 3 things the patient sees. I'm going to skip that for now. Okay, so how do I logistically go about doing this? So right now, this is the follow-up right here. It's super helpful to not put follow-up with cardiology, but follow up with Dr. Shrichak. So whatever name is in there, again, my office knows to send the discharge summary to that person, and then they make sure that they get the document. Just type in the person's name, they'll pop up. It's actually a pretty robust system. If you want to free text something, like let's say I discharge a patient to hospice, and I just want to be like, follow up with hospice. You put that in this little plus sign right here. It'll give you like a free text area to put that in. The PCP is here. Make sure it's accurate if you're going to use that, but you can click it and it just says follow up with your PCP, and then you can add, I'll show you, when it pops up, you can say within 2 weeks or on a date time, like your appointment is this date and this time, and you can put like comments down here. So bring your medication list with you, or this is your orthopedic surgeon if they might not have met them before or something like that. All of this information the patient sees. Next section is the patient education. Yes.
Sometimes they'll have their appointments automatically in the EMR.
Great
Is there
question.
any way to like just tag that?
I have been fighting for that for like, you don't even know how long, probably before you were here. Yeah, it doesn't make any sense. I am working on it. So if you, like, you can see the appointments, patients can't see them, and it makes absolutely no sense whatsoever. So we just have to put them back in this section. Do know I am fighting for it, but changes come slow. Maybe before I leave next year, who knows.
Is it wrong if, let's say they have a scheduled follow-up appointment,
Uh-huh.
and instead of like finding providers, typing in the date and time again, putting those in the patient education, that I just click like follow-up with EMOC or something?
Yeah, I mean, whatever way makes the most sense for that patient. So like, is the patient going to see it? And if the answer is yes, and it's the information they need, do it whatever way you do it. Yeah. I will say though, you have to have something in the follow-up section for this little red asterisk to go away. Otherwise, it won't let you discharge the patient. So that's one reason to do it here. This is the patient education section. Sorry, I know this is hard to see. And you've probably learned this by now, but if you click on the plus sign, or I've saved these to my favorites now, we have this one in particular, this AAA created by Dr. Sankrat. What that is basically just a blank free text area. This was your hospital course. This is what happened. This is what we found. These are your follow-up instructions. So most of us use this. Is it wrong if you don't? No. Do whatever makes sense to you. There is another one created by Dr. Abelos. So if you look for AAA with Abelos' name on it, that's a little more straightforward. You were hospitalized for. We treated you with. When you're discharged, you should. Or you can create your own, whatever works for you. One of these days, I'm going to add in a section here that says medications changed, because I think that's important for the patient, and we don't have that capability yet. So consider including that as well. So here's my big hint to you. When you write these special instructions, this is what you want the patient to see, right? So take your Lasix, twice a day instead of once a day. Finish your antibiotics. Follow up with your primary care doctor. Weigh yourself once daily. Whatever. Write it all in there. Highlight and copy, and then I'll show you where to paste them. That will be in the discharge order set. So here's my order set. This is just the basic one. I have to put in this one up top, which is the discharge the patient order. I can click here whether I want home or STAR or hospice or whatever. And then I have all these choices. So this is like activity level, instructions, diet, wound care, follow-up. Again, you don't have to do any one of them, but do whatever makes sense for the patient. And what I tend to do is just include everything in one, because again, I don't like extra clicking. So all those things that I just copied from the patient instruction section, where I'm going to paste them, skip over that, sorry. I'm going to right-click, modify the discharge instructions, and then there is, if you're in this little like details thing that pops up, there's like a one-line thing that's really difficult to type in and read, but if you click over to this comment section here, you can paste whatever you copied from the discharge workflow area. So I know that was a lot, but when I do this all in order, what I do is I go through my problem list, my follow-up, my med-rec, my education, copy that education, do the order set, paste it into the order set. So I know that seems like a whole lot right now. The first time I did this was like, 90 minutes or more of discharge stuff. Now I can do it in 20. So there is a light at the end of the tunnel. This does get easier and easier as you go along and practice it. Yeah.
So for the patient education and this discharge instructions,
Yes.
is it in theory redundant?
Yes. The reason I paste it here is because this way it goes into the summary also,
Okay,
not just the patient seeing
because
it.
I haven't done this once yet.
Yeah, because most people don't, and it's understandable. Like, the reason I give this talk at the beginning every year is because it's hard to perpetuate. If people forget, things wear off. Totally understandable. I'm just trying to make your lives as easy as I possibly can.
So go to the summary, which will go in the PPT as well.
Exactly.
We'll see what you told them.
Exactly. So I like things where I can show the patient, and I can show somebody else what I showed the patient, and this will do both of those things. Yeah. Did you have questions?
What's the way to see what the patient will see?
That's a great question. In the documents list, when you create all this, it'll pop up something like exit note or discharge instructions or something like that. That'll show you what the patient sees. But you won't see it until you do this.
Oh,
Okay.
yeah, just sorry, I haven't done them yet.
No, that's okay. That's why we're here. It's not intuitive. I know this is hard. If any of you came from Epic, I apologize. I don't know what I'm apologizing for. I don't have anything to do with MedCon. I just know how to work around it. So when you actually do the order set, so I did my discharge patient, I did activities as tolerated, here's all my instructions, I told them to do a regular diet. This is what happens in my discharge summary then. So I have all this information automatically in there. I don't have to copy and paste it anywhere. This is what my end product looks like. Orders, activity, diet instructions, and then my follow-up appointment information that I put in. Okay, we are so close, guys, so close. You may have noticed there's a pending results section now that's new. Free text only, MedConnect doesn't have the capability to do that, so what's the easiest way to do that other than planting it in your memory? Well, if you look at the Summary 2 view, so again, we're on this dark gray section, come up here to Summary 2, scroll down on the right, and this is a pending list of things that have been ordered but have not resulted yet. You can copy and paste this, highlight, copy, and paste. Of note, though, this will not include pathology. So if you're waiting on any biopsy results, you'll have to note that. There's no way to find that out. Lastly, almost, there is a section for past medical and surgical history at the very bottom. You will have probably already noted that it's of dubious quality. It's not terribly helpful. It's listed diagnoses that may or may not be accurate. This section is here because somebody at their hospital asked for it. Personally, I think it's useless and clutter, and I don't want to see it, so what I do is I delete it. You don't have to do that. You don't have to be as, OCD about things as I am, but feel free to do it if you're, anti-clutter like I am. And then very lastly, the time spent on discharge. I see every year the new interns saying, 100 minutes spent on discharge, and I feel so bad because if you're attending, it doesn't matter. Medicare doesn't care how long it took you. It cares how much time I took. Just leave it blank and let your attending know. Sorry. Okay, so just to review our general tips. Be concise. Less is more. Don't go crazy. Make this as simple and straightforward as possible. I am old enough to come from a time where I dictated this instead of typing it all in, and I will tell you it was faster because it had to be. I just had to summarize it all real quickly, and I talked into the phone for 15 minutes, and that was it. So kind of think back to the good old days. Don't think you have to include every single detail, okay? Remember your audience. Think about what they're going to need to know. Think about what they're not going to need to know. Make it easy to read. Make your life easier. Keep track of all these shortcuts as you go along, and get